All right, welcome everyone back to another virtual shadowing session at Hearts for Health. I hope your month of January is coming to a nice close. It's gone by pretty fast. Can't believe it's almost the end, but so far it's been strong for me. I hope it's been going well for y'all. I do have a couple reminders before we get started for today's session. Today we're joined by Dr. Hassell. He's an anatomic pathologist at the University of Oklahoma. He'll be talking a little more about the specialty, about himself, and we'll get to see this specialty for, I think, the first time on virtual shadowing. It's definitely going to be exciting. But in terms of those reminders, especially if y'all are new, we have a Q&A at the end of each of these sessions. So if you have any questions about Dr. Hassell, the specialty of pathology, feel free to type in the chat and we'll cover them towards the end. We usually have a good 10 minutes at least for a Q&A. So we're usually able to cover all the questions. And like I said, any point in time, feel free to drop them in the chat, those questions you have. Also, we do have more sessions, usually on a weekly basis. They are planned for either Mondays or Thursdays. And in order to stay tuned with the speakers and specialties we have, feel free to either follow us on Instagram, where we post our flyers, or you can also subscribe to our listserv, which is a weekly email we send out, including our speaker flyers, as well as a couple other programs for mentorship, for clinical and non-clinical volunteering. Those are all of my reminders. I want to keep it short and sweet, but if you do have any questions for us, feel more than free to email us. Our email is community@hearts4health.org. And I will also be including the email address at the end of today's session in the video description below, in case you didn't catch that. But with that said, Dr. Hassell, feel free to take it away.
Well, thank you very much, Michael. And I'm pleased to be here and really excited for the chance to interact with a little bit younger crowd than sometimes I deal with in my daily work, which includes mostly residents and medical students and so forth, as well as, of course, all the staff and faculty in the laboratory and in the hospital. So I think it's always valuable to kind of ask, who is this guy? What does he have to say? What might I learn from him? And, you know, Michael's mentioned pathology. And when I tell people I'm a pathologist, they think that this image represents my second home, the morgue. But in fact, that is far from the truth. Although pathologists are and can be involved with autopsy pathology, for the vast majority of pathologists these days, that's a relatively minor or even non-existent part of their day-to-day work. So I'm not going to cover autopsies or show you any gross, crime scene photos, although you could find plenty of those on, primetime TV, I'm sure, if you're interested in that sort of thing. And generally, there are some good series that cover the accurate portrayal of those issues within the realm that the TV can do that. So just a little bit about my background. I went to school at the University of Utah, and I was blessed to marry a young lady whose father was a pathologist. And I had considered pathology a little bit beforehand, but it really wasn't until I saw, what kind of a brilliant mind he has, what kind of challenges he dealt with in his life, that I made the decision to go into pathology. Although I will say that I was a little apprehensive about being compared to him by either my wife or anyone else because he was such a stellar physician. But that being said, after graduation, I was fortunate to move to Boston, where this very historic institution is located. This is what's called the Ether Dome, which is actually the very first place where anesthetic surgery was performed. At that time, a part of the Massachusetts Hospital, now known as Massachusetts General Hospital. And while I was there, I had the unique opportunity to come under the instruction of a truly marvelous teacher. And I think that's very important. And as this was part of the reason I went there to train, is because I wanted good teachers. Indeed, this gentleman, Dr. Robert Scully, was a wonderful gentleman, very humble, but also extremely bright and capable. For many, many years, he was the editor and author of the what were called the clinico-pathologic conferences, which were held often here in the Ether Dome and so forth, and then later published in one of the premier journals in medicine, the New England Journal of Medicine. And so I had the opportunity during my 4 years of training there to get to know him really well and to appreciate his talents and to in some ways try to model myself after his career. I will tell you one little interesting sidelight just to sort of illustrate the kind of his approach to life, if you will. And mind you, this is someone who was internationally famous, recognized as probably the premier authority on ovarian tumors and gynecologic disorders, and obviously was very honored to be, an editor, section editor for New England Journal and running the CPCs and so forth and so on. And yet none of those honors and awards were what decorated his walls. Instead, he had one certificate on his wall, which was his graduation certificate from Tucker Junior High School. And of course, you might chuckle and laugh at that, but I think it says something about him as a pathologist and to some degree about pathologists in general. They're a little bit unassuming. They're not flashy and showy and egotistical as a general rule. That's not to say that there aren't some that are egotistical and so forth, but their models and their demeanor tends to be people that are unassuming, but enormously capable and, if not brilliant, at least well above average. So after I left Mass General, I practiced for a while in California, and then later I joined a group of pathologists in Maine, where we had a very regionalized practice serving up to 18 hospitals in most of the state of Maine, and had a great experience driving around the back roads on snowy days like some of the recent times to attend meetings or care for patients or otherwise. Most of our work we did in Bangor, which is a beautiful little small town, actually medium-sized town, but which serves an enormous population as its commercial center. And so it was a great place to work and learn and serve. But after that, after sort of working there for many years, the call of teaching and academia got to me, and I was persuaded to not fly over Oklahoma, but instead land here at the University of Oklahoma, epitomized by the SOAR here. And I've been here for the last 16 years or so, working in the pathology department here and having the opportunity to teach students in medicine, students in dentistry, students in nursing, pharmacy, other allied health fields, as well as to take care of the patients who come to our hospitals and so forth. So it's been a very enriching experience. And I'm going to talk about some of the different roles that pathologists have as we go through this so that you get an idea kind of the variety of careers that are possible in pathology and the kind of problems that we deal with day to day. So among those problems are the challenges that are associated with the unequal distribution of pathologists. So if I were to show you a map of countries with good healthcare, they would really coincide to where there are ample numbers of pathologists. And if you were to look at countries where you wouldn't want to get sick, you wouldn't want to have surgery, you wouldn't want to have cancer, well, those correspond to the countries that have far below the adequate number of pathologists. And that has become, for me, kind of a passion. And so after coming to the University of Oklahoma, I persuaded some of my colleagues, who you can see here, Dr. Bain, Dr. Zuna, and Dr. Fung here, wonderful colleagues that I met and became associated with here at the University of Oklahoma, to join me in doing some teaching in other countries. And one of the places that we went was Vietnam. And this is one of the hospitals we visited in Vietnam, where they were really only held back by their lack of experience, lack of equipment, space and money. But we had wonderful interactions with their faculty, their trainees. And in fact, many of them eventually came to work with us for periods of time. And we've helped to continue to mentor individuals in those practices over the decades. In fact, just this last week, I received a number of consult cases from a colleague in Hanoi. In addition, that led to a period of time where I said, you know, I'm ready for a sabbatical. I'm ready for a little break from the day-to-day work. And that's one of the things you can do in academics is take breaks like that. And so my dear wife and I had the opportunity to actually go and live in Hanoi for 3 years. And during that time, we did a variety of teaching and educational things in hospitals, working with the National Cancer Center, working with our colleagues in Hanoi, Ho Chi Minh City, and Hue, Da Nang, and other major areas where the medical care system was still developing. And so I've got to the point where I feel like the 500 or 600 pathologists in Vietnam are like brothers and sisters to me. They're really dear people, and I've had the opportunity to do a lot of things with them. And as you can see from the smiles on our faces, that was one of the things that made us really happy there. Of course, in the course of that, we made a ton of friends. And these have become really lasting friendships in our lives. Very, very meaningful to us. Of course, very different culture, very different medical system, very different government and political system. And interestingly, we had the opportunity to be in Hanoi at the time that of the election in 2016, and many of our friends there at that time kind of asked us about how this could happen. And they said, you know, we have a certain way of choosing and selecting our leaders, and I'm not sure that your way is necessarily better, which was a surprising and challenging little political commentary for our time, and certainly gives us pause as we watch potentially a repeat coming forward again. But I'm not here to talk about politics. So after returning there, we came back to the University of Oklahoma, and a lot of our practice is related to cancer. We are the fortunate location for one of the National Cancer Institute designated cancer sites, the Stevenson Cancer Center here in Oklahoma City. And that means something because, and just to sort of let you know what that means, an NCI designated cancer center has access to the latest in terms of patient clinical trials. So access to many of the most promising drugs and regimens that are available for treatment of certain cancers. And this has made our practice here very, very interesting because it means that very complex patients, very abundant numbers of cancer cases come into our institution for treatment, and therefore come to me and my colleagues here to look at them, to reevaluate them, and to give them a name. And that giving them a name process is extraordinarily important because it's that naming process that essentially writes the prescription and says this patient is eligible for this trial, or this patient should get this drug and this regimen because of what the pathologist has said about their cancer. So we like to say that the cure can't begin until the pathologist makes the right diagnosis. And an accurate pathologic diagnosis is absolutely critical to getting the right kind of care for a patient with cancer. So a lot of what I do day to day is like solving puzzles. And if any of you like to do puzzles and brain teasers and so forth, you might find that pathology is very interesting. As I went through medical training, I discovered that that was the part I found most challenging and engaging and fascinating, was solving those problems. The interesting, challenging cases. We would have as I was a medical student rotating in the clinical wards and so forth, we'd look at their laboratories and some of their things. And then eventually the clinician that we were working with would say, well, I guess we're going to have to go see the pathologist and see what they have to say about this. And just time after time after time, it seemed like we were always marching down to the pathologist's office or marching up to the pathologist's office to find out what the answer was. And so I quickly learned that pretty much all the interesting cases in the hospital eventually siphoned through the laboratory and by the eyes of the pathologist. So for me, that being the most exciting part of medicine, I said, I think I want to be where those interesting cases come and have the opportunity to participate and help in solving those puzzles. Because although some things are very straightforward, the body is pretty limited in terms of the kinds of reactions that it can produce. And we'll talk about some of those clinical symptoms here a little bit tonight as we walk through a couple of cases that might be of interest to you and so forth. But that's what pathologists do. We solve problems and deal with puzzles. And sometimes they're just as jumbled up as this set of puzzle pieces here. And you don't necessarily always have the big picture in front of you to guide you as to which piece needs to go where and so forth. You may be able to pick out that, oh, this is an edge, but you don't necessarily always know where they're going to fit together and what the final picture is going to look like until you start to piece all of those little clues together in your solving the mystery. Now, when I give lectures to the medical students, and we also give them kind of the spiel about what do pathologists do all day and so forth. As I mentioned, my wife's father was a pathologist, and of course, back in those days, they didn't have formal, take your child to work days, but she nevertheless went with her dad fairly often, and eventually came to the conclusion that what he did most of the day was eat candy bars and look through the microscope. Because as she looked in the wastebasket, there were all these candy wrappers, and she saw the microscope on his desk. But that's just a little aside here. One of my colleagues says, well, I like pathology because I get to play with the coolest tools. So, you think of things like a digital microscope or an artificial intelligence algorithm. Pathologists get to work with those. You think about Molotov, magnetic resonance imaging cytometry, or flow cytometry, or other sorts of things. These are tools that pathologists use every day. Monoclonal antibodies, immunoassays, ELISAs, and so forth, immunohistochemistries. These are exciting tools, very powerful tools, that are the bread and butter things that pathologists use. And so one of the reasons to enjoy pathology is that the technology is always advancing and enhancing and challenging your abilities with regard to that. Another reason I tell them that pathology is particularly useful is because it's very diverse. You have a wide array of patients and ages and organ systems that you're dealing with, everything from the tip of your head to the bottom of your soul and everything in between. Age group from prenatal to 100 centenarians and so forth, and all the organs within the body. And additionally, because of your study and your training and the tools you have, you really come to understand the disease and why it is the way it is and what's driving things, much more than many other disciplines. And then, of course, lastly, you get to tell surgeons what to do. There aren't very many people who can tell surgeons what to do, but the pathologist does. As I said, we write the prescription, we tell them what the margins are, we tell them if they've done a good job and whether they need to take it out or not. And that's a feeling of power, if you like to be in a powerful position. Lastly, and that is the people in pathology. I've already sung the praises of Bob Scully, but that sort of personality and the qualities of people that you find in pathology is very, very rich. It's very diverse, and it's I wouldn't say that it's abrasive. It's not competitive because pathology, we recognize pathology is a team sport. And I think it's because of that that our egos don't get in the way. But we're able to work with people from all over different kinds of backgrounds and so forth. So this is an image of some of our recent residents in our program. You have people from Mexico, people from Oklahoma, people from Texas, people from Lebanon, people from Iran, Iraq, South Asia, various other places, as you can just see in their faces. Men, women, all of these, the above, and they're just fun to work with. And so, as my colleague Eric Glassy says, as a pathologist, you really can travel the world, meet interesting people, and they're all nice, and that's pathology. So I've found it a very rich and rewarding experience. Now, I will just mention here in passing, I do have a YouTube channel. And if you go to my channel and check out the playlist about conversations with pathologists, why I love my job. A few years ago during COVID, I interviewed a number of my colleagues who were working in different niches in pathology to find out what they liked about their job, what the problems were they dealt with, what their frustrations were, what their daily workload was like, and those sorts of things. So for a little bit more in-depth review of various fields in pathology, feel free to take a look at that playlist. Here's a little bit more of the details. So I think there are about 25 or so videos on that playlist. So I'm going to stop that particular piece of our talk and go on and talk about some cases. And so I'm going to share my screen here again with a different application here and share with you a case that came to our attention recently. This is a middle-aged gentleman who is having some difficulty swallowing. And I like to sort of begin with the symptoms and think through what can cause those sorts of things and why. And so, and I like to sort of start with that and just sort of ask ourselves the question, what can cause dysphagia? This is a very non-specific term. So dys means not functioning properly. Phagia is the process of swallowing and so forth. So the anatomy, we have the mouth here and so forth. Then you have the trachea here to the anterior, and the esophagus here is where you can begin to have difficulty with that. And that esophagus passes through the thorax into the stomach. And so anywhere along this path, that food getting stuck or a feeling of it moving slowly or whatever can give you that sense of, I'm not being able to swallow normally. But when you start to look at the mechanics and the physiology of what's involved here, it gets pretty complex. And so these sorts of algorithms are what keep gastroenterologists up at night and radiologists as well. But pathologists also think in these sorts of terms. What kind of thing is it that's causing the process? And are we supposed to be thinking about something that's structural or neuromuscular? Is it something that's related to function of the distal esophageal sphincter, or the point that pinches down and keeps you from regurgitating your stomach contents up into your esophagus? Or is it something up here in terms of protecting your airway, getting things into that process? Or is there, something mechanical? So all of these different entities here, from cancer to central nervous system tumors to degenerative diseases like Parkinson's disease or multiple sclerosis, those sorts of things, all of these can cause dysphagia. Then we start looking at things like achalasia or Chagas disease, which can be related to an infection. Those can cause, dysphagia and so forth. So, and even some of the esophageal rings or strictures can be related to nutritional deficiencies, like iron deficiency and so forth. So it's really a diverse realm of things that can cause a single symptom. And if you're just thinking, well, it's got to be cancer or non-cancer, you may miss the boat and so forth. So in this case, the patient's dysphagia seemed to be a little bit more solids than liquids, and it seemed to be esophageal rather than upper oropharyngeal. So we were thinking probably more likely, something in this realm of things. And as you can see, the choice of evaluation here includes esophagogastroduodenoscopy. That's what the EGD stands for here. So what did that look like? Well, here's a nice example of what would be seen using the endoscope. And so here's the endoscopist looking down the esophagus. You see these sort of linear furrows and so forth, and bang, we've got this little bulbing thing here that's sort of sticking into the lumen and probably could cause some solid things to sort of stick there and provoke that sensation of dysphagia. So what is he going to do? Well, we don't see any difference in the coloration of this lesion. So it looks like the surface of it looks like the rest of the esophagus, which is covered with a type of cells that are relatively similar to what's in your mouth or on your skin. And so it's probably not a surface-derived tumor, but it looks like it's sort of coming from the wall, so sort of bulging in. So they would, in this situation, probably want to do a biopsy. And when they do endoscopic evaluation, they have the ability to insert a flexible probe in that has some tweezers on the end that can sort of grab or detach a piece of the tissue that is at the end of those tweezers. They also sometimes have the capability to do needle core biopsies, or little narrow core biopsies of a lesion like that. So either of those methods would probably be their approach of choice. Probably more preferable would be the needle core, but it's generally fewer people who are able to do that. So a biopsy was done, and the lesion was diagnosed. But when we're thinking about the kinds of tumors that we might see in this situation, there's a variety of tumors that can be present. Now, I've mentioned that the surface epithelium can give rise to certain kinds of tumors, usually things like squamous cancer or adenocarcinoma. But there are also some other types of tumors that can occur here. There are some salivary type glands that occur in the esophagus, so they can produce tumors. There are neuroendocrine cells that are kind of the connection between your neurochemical axis of your brainstem and your spinal cord and the surface epithelium and so forth. So they can occasionally produce tumors. And then sometimes you can get tumors that come here that came from someplace else. They like to travel, and they found a suitable place here in the esophagus. So metastatic or secondary tumors could also be considerations. Now, in addition to the surface epithelium, which is the most common source of tumors, the underlying structure of the esophagus, which includes blood vessels and muscle and nerves and occasionally fat and so forth, those tissues can also give rise to tumors, both benign and malignant. And so in that setting, we would be thinking, in our case, well, which of these are possibilities? Is it from the smooth muscle, which surrounds the esophagus and helps to propel food downwards to the stomach? Is it from the nerve component that's in the wall? Things like schwannomas or neurofibromas or those kinds of tumors? Could it be something that's called a GI stromal tumor, which is a really quite unique tumor, and we'll actually look at one of those from another organ a little bit later on as we have time. Or could it be even something else, something beyond those? These are the most common ones, but fat and other cells involved can produce tumors as well. So as I'm looking at the story and the history, I'm thinking it's going to be something on this side of the equation, but I don't know which of those it's likely to be. So here's a sample of a small biopsy, and I'll just sort of walk you through what this looks like. This is a digital slide, a scanned slide. So when the surgeon or the endoscopist takes a biopsy, we can't just immediately look under the microscope to get that. We have to process that in a particular way using a variety of chemicals and so forth. And then it's embedded into wax. And that wax then becomes the substrate that allows us to cut a very thin section and put it onto a glass slide. And then once it's on the glass slide, you can get rid of the paraffin, so forth, and apply other chemicals. In this case, the two most characteristic chemicals are hematoxylin, which is a blue dye, and eosin, which is the pink dye. And the hematoxylin will stain the nucleus of the cell. It tends to stain acidic items. So nucleic acids are acidic, and they take up that stain. Whereas the eosin tends to stain things that are more neutral, proteins, polysaccharides, and so forth in variable degrees. And you can actually get kind of several different colors, as you can see with the eosin, ranging from a reddish color here through a pale pink to a more amphiphilic color and so forth. So you get multiple hues in that color that allow you to distinguish the tissues. So here I'll just review kind of the normal anatomy of the esophagus. So here is the surface. Here is the squamous epithelium. And beneath the squamous epithelium are a few blood vessels and some loose tissue. And these blood vessels extend up into these little projections here to supply nourishment to the surface epithelium. Then in addition, just beneath the surface, you have these bundles of pink cells here, which are little bands of smooth muscle. And they help to sort of allow the mucosa to stretch and contract and so forth, and will also contribute somewhat to peristalsis. Deep to that layer of muscle is another area of larger blood vessels. And then further beneath that would be the outer muscle layer of the esophagus. Of course, you don't want to do a transmural biopsy and leave a big hole in the esophagus when you're trying to go after something. But we can sometimes take either pieces of the surface, or in this case, they've done a little endoscopic resection and cauterized a loop of it to remove this piece of tissue. Now, in contrast to this piece, which is fairly normal, we look at this piece and we see that there's something that looks different. And so as we come into look at this, we can see that this comes right up to the epithelium, these cells, and it's just right up against the squamous epithelium. And it sort of interrupts or displaces the smooth muscle. And it has fairly sharp margin, although there may be a little bit of spread laterally around it. Now, you may see some dark spots here. These are an artifact of somebody's fingerprints or a little bit of dirt on the slide that were there when the image was taken using the digital slide scanner, one of those fancy tools I mentioned. And so that allows us to look at the slide, but we also recognize that sometimes our little artifacts, if we're not careful, can get in the way. So let's look at these cells that are causing this process and just take a look at it. I'll just ask you to maybe type into the chat what you think about how you would describe the cytoplasm and the nuclei of this process. Are there any adjectives that you think would describe well this process? When we're looking at a tumor, in order to decide whether it's benign or malignant, we look for features of architecture. We look for features of how it's related to adjacent structures surrounding tissues. Is it sharply demarcated, or is it kind of infiltrative? Is it jagged, irregular? We look for the kind of structures it may be making or mimicking. And then we look at some of the characteristics of the nuclei. Are they uniform or irregular or atypical? Do they have evidence of rapid growth? Do they have so what we call mitotic figures, or evidence that the cell is in the midst of division when it was caught in the biopsy? And those kind of features. So did we get any comments in the chat yet, Michael?
No, not so far.
Okay. All right. Well, wake up, you guys. So if I were looking at this, I would say this looks like there's a lot of very granular or grainy kind of pink stuff in the cytoplasm. And I don't see any distinct borders between the cells. And that is pretty much the name of this tumor. This is called a granular cell tumor. Well, what does that mean? So we've given it a name, and that's a descriptive name in terms of what it looks like, what the cells are. But what do we understand about that? How can we further decide how this is going to behave? So one of the ways we learn how these things are behave is by retrospective studies, looking at the outcomes after similar tumors that looked this way and reacted this way with our hematoxylin and eosin have behaved. We also now have other tools that allow us to characterize these tumors. And we can see them in other sites. So this is a similar tumor that was found beneath the surface of the tongue. And in this one, the cells are a little bit more spindly, but they still have somewhat this same granular kind of appearance in some areas. So this is much more pinkish fibrotic material, but also would fit into this category of granular cell tumor because of this very granular cytoplasm, which we can see here a little bit better in the deep portion of this tumor. Then what do we know about these tumors? So granular cell tumor, well, fits into these categories of other tumors that we might think about. I'm not going to talk a lot about that. So let's jump forward to look at what a granular cell tumor is. So this is a tumor that can occur at a variety of locations in the body, on the skin, and I've mentioned the tongue, but in the GI tract, the esophagus is the most common location where it can occur. And sometimes when it occurs, it causes the epithelium over it to become hyperplastic or to grow in a more uncontrolled fashion. It's typically fairly superficial in the esophagus, and it rarely becomes malignant. If it does recur quickly or is a large thing, then we would think more about malignancy. But things like areas of necrosis or death of the tissue, a very high cellularity, mitotic figures, and more cytologic atypia are very common. So this tumor stains with a couple of different other stains besides the H and E. So one of the tools that pathologists have used for a long time are various histochemical stains. So all of the things you learn about in organic chemistry or even in basic chemistry can be applied to tissue in various ways. So things like the acid shift reaction, the periodic acid stains, and so forth, those can be applied to tissues and can teach you about some of the substances that may be in the cytoplasm and so forth. But we also now have immune markers using monoclonal antibodies, sometimes polyclonal antibodies, directed at particular types of antigens. So one of the first ones that was developed was S100, which was thought to be a fairly specific marker for a nerve-derived tumor. And so things like Schwann cell tumors, neurofibromas, those kinds of tumors will often stain with the S100 stain. But as time goes on and we stain more things, lo and behold, these things that we think are very specific at the beginning turn out to be rather widely distributed. And so someone once remarked, the best time to use a stain or a marker is when it's first introduced, because that's when it's the most specific. Well, in fact, that just describes the fact that over time, we learn that these things cross-react with other things. So the fact that the granular cell tumor is positive with this S100 marker does not mean that this is a nerve-derived tumor, although initially people wondered if that might be the case. And in fact, it reacts with other markers called CD68 and calretinin, which are, again, themselves rather non-specific markers that occur in a variety of locations, including mesothelium and ovarian stroma and other types of lesions as well. And the CD68 can react with benign tissues, granulomas, and so forth. So while this complex is consistent with making this diagnosis, it doesn't really tell us exactly where these granular cells come from. We think they may have a neurogenic origin, but we really don't know the bottom line of where they come from. And we do know the behavior. Most of these are benign tumors, very rarely recur or develop malignancy. And so that information can be provided to the patient. So that was one of the cases that I wanted to share with you. I'm going to switch gears here a little bit and talk about some of the other things that I get to do in my consults and so forth. And I'm going to, so I mentioned one of the things that we can do is to provide international consults in our work. And one of these came recently from a colleague in Africa. Let's see if I can get to the first slide here, and then I'll show it to you here. So my friend Aisha sent me this case from Ethiopia, and it was a kind of an interesting challenge for her. Now, she was not able to share with me the slides. That would take a few weeks for the slides to arrive, probably. But because she had a little camera, maybe even a camera on her phone, she was able to take some photographs of both the gross specimen and some photographs through the microscope to share the case with me. Now, these are not the best pictures, but they illustrate how she was struggling with a problem. And because we're on the same team, we could help each other. So this was a young woman who was actually pregnant. She was 12 weeks pregnant, and she was discovered to have some abnormalities in her chemistries, one of which was an elevation of this marker called CA125, which kind of indicates that there was something going on in her abdomen. It's usually elevated when there's some sort of disturbance to the surface of the abdomen. Well, this was before she was pregnant, so that was abnormal at that time, and that was not what you would expect. So they did some studies and found that she had a complex right adnexal mass. Adnexa means the tissues of the fallopian tube and the ovary that are adjacent to or adnexal to the uterus. She also was found to have, of course, an intrauterine pregnancy. And there was some fluid, and they were concerned that she may have a malignant ovarian tumor. And that was because this is both solid and cystic. The ultrasound can nicely distinguish solid tissue from fluid-filled tissue, and so that's very useful in defining those sorts of lesions. So given that concern and the fact that she was still early in pregnancy, they decided that they would need to remove this mass. So they did so, and they sent the lesion, the cystic lesion. They sent some peritoneal biopsies and pieces of the omentum, which is the fatty tissue that sort of drapes over your bowel inside the abdomen. So this is what the interior of the ovarian tissue looked like. It's very grainy and sort of, how would you describe this? Sort of papillary, I guess. It's kind of got all these little excrescences on it, a kind of complex looking lesion. And as you can see, she took that with her digital camera. Under the microscope, she saw this. So those little projections that we saw, the excrescences, had a core of loose tissue here and a surface that was lined by these cells with sort of columnar pointing ends on them. And there's a little bit of sort of, unevenness to the surface, a little bit of atypia. You can see a few larger nuclei in this. So these were concerning to her that this was a neoplasm, and it might be a malignant neoplasm. Whoops, wrong direction. Here's a little lower magnification view, and you can see, again, these little papillary areas and a lot of the little excrescences even off of those. So I'd introduced you to Dr. Scully before, and this is a tumor that Dr. Scully studied a great deal about and was able to classify as a serous tumor, meaning that these cells looked like the cells that line the serous cavities of the abdomen or the thorax and so forth. And because of the complexity here, these were tumors that had a variable outcome, and it was difficult to predict their outcome. And so he invented the term borderline tumor for these tumors. So they became known as the serous borderline tumor. A little bit later, with more information and more study, we discovered that some tumors that have a lot of this very micropapillary projection type of appearance tend to behave a little bit more aggressively and potentially to recur and to be more concerning. So usually the tumors that are just pure borderline tumors don't have quite the same bad behavior, but the more micropapillary they become, the greater the risk of them spreading and being potentially malignant. And one of the defining features for that is the presence of areas of invasion or spread to other organs, so spread to the omentum and so forth. So that was the reason that my friend sent me this case, was to look at whether there was stromal invasion. And so she sent these pictures, which I looked at and said, yeah, they may look like it, but that's not true stromal invasion. That's not true stromal invasion. This is a higher magnification view. That's not what we see with stromal invasion and so forth. So I was able to help her with that. sort of process. So, and so I was able to answer her questions and give her some suggestions, and I think that will help to guide her treatment of this patient. Well, I noticed that we're running down on time, and I want to leave you some time for questions. So I think I'm going to stop at this point and just see what we can pick up for questions from people about pathology in general or some of the things we do. Because I think you've gotten the sense that I look through the microscope a lot, but I do a lot of other things. I do a lot of teaching, teach patients, teach other doctors. We have tumor boards where we talk about these cases and tell the surgeons what to do or tell the oncologist what drug to use and so forth. And then there's also the discovering new knowledge piece of my job. So those are all exciting parts of being a pathologist that we could go into more detail on, but I'll leave some time open for you to ask questions.
Yes, well, we do have quite a few questions, Dr. Hassell. But first of all, thank you so much for gathering together this presentation. Our students just love to see cases. And like I said, one of the first times we've had pathology on virtual shadowing. So I learned a lot. I'm sure other students did too. But for our first question, a student was wondering, how much volume do you see on average in terms of cases? And if you could separate that volume into, I guess, tough cases that might take a while versus ones that are more bread and butter. I know that pathology is a very kind of by site sort of specialty, right? Just like I'm sure other specialties like dermatology, I know, are characterized as being. So do you find that it does take time in getting through cases, or is it pretty quick?
Well, a lot of that, the answer to that depends on the setting in which you practice and the nature of the environment that you're in. So when I was practicing in Maine, we were drawing cases from all over the state, but mostly from small hospitals and doctors' offices and clinics and so forth. We did have a couple of larger hospitals who would have some more complex cases. But a lot of our work was biopsy work and so forth. Now, having said that, there's no market, or there's no corner on the market that only the academic centers will have the interesting cases. We had interesting cases every day. And on average, in that practice, I was seeing, 30 to 40 cases a day, sometimes more, sometimes a little bit less. And out of that, there were usually, 2 or 3 cases that were quite interesting. The workday in that setting, you would usually work through those cases generally through the morning. You would get through that first pass, see which cases needed more workup or needed somebody to do stains. In the afternoon, you'd work on evaluating any of the gross specimens, getting your report signed and looking at the special studies and so forth. In my practice now in an academic environment, because I'm doing teaching as well, I don't see quite as many cases, but I'd say I probably see a lot more interesting and unusual cases in that mix. And so there tend to be more large resections, multiple part resections. We have a liver transplant service here, so we see more liver resections. We have the complex gynecologic cancer cases, so you see a lot of ovarian and uterine resections. Whereas in a private practice setting, you were just seeing hysterectomy for fibroids or something like that, and occasionally they'd have a cancer or something like that. But having said that, all the interesting cases really do come to pathology. And that's not just in the anatomic side of things, it's in the clinical lab as well. Patients with complex coagulation problems, or patients with complex blood bank issues, or cases with difficult microorganisms and so forth. And it's very much dependent on the nature of the practice where you're working. It also depends a lot on your level of experience. When I was a young pathologist, I was more inclined to send cases for consultation because I was seeing a lot more new things that I hadn't didn't have a lot of experience with. So if my colleagues or partners didn't know what something was or weren't sure about it, I would send it to a friend in an academic center or something like that. Get the team involved on caring for the patient. Whereas now I see a lot of interesting cases, but I usually can show a colleague who's around the next office or down the hall, and don't have to send something to Mass General or to Mayo Clinic or something like that very often. Now, patients still go to those places with their cases, and we get their reports back. So we always are learning from what other people say about our cases as well. But there are always interesting cases. And I'll contrast this with a fellow that I went to medical school with who was a pediatrician. And he ended up doing very much an office practice with occasional hospital duties. But as we were talking one day, he said, well, we always have kind of the case of the week, that we're looking for. And I thought, case of the week, if I were to rely on case of the week, I have case of the day. I mean, every day there's something really, fascinating, or I haven't seen that quite that way before, or I better show this to somebody to make sure that they agree with me on this sort of thing. It's a very stimulating area, and you're always discovering new things that you haven't seen, maybe others have seen, and learning new ways that the body and disease can perform. And of course, we're always inventing new medications and treatments, and that influences what we see as well. So we now have diseases that are related to some of the checkpoint inhibitors that are used in cancer therapy that we never saw when I was a trainee, of course.
Well, I'm glad we saw that side of the specialty. A lot of people, I'm sure, think, just like you said at the beginning, your office is more or less right next to the morgue, or at best you'll be behind the scenes of a show like Forensic Files. But like you said, it's definitely very stimulating, and very interesting. Cases of the day instead of cases of the week, like you said. One of the other questions we had to do with, you mentioned sort of, I guess, along your way in practice, you took sabbatical for 3 years, right, in Vietnam. Over that time, they were just curious, how well do you feel like you adjusted to, I guess, learning the language over just those 3 years, and I guess living life as a doctor on break, right, in the middle of practice? What was it like?
Yeah, that was a real challenge in a lot of ways. Now, first I'll say that I had learned the language as a young man when I'd served as a missionary in Saigon in 1974 and 75. So I had some language background. It wasn't medical language, but I was able to communicate and get around quite readily, and I felt at home in that regard. And I'd also visited there multiple times, as I showed you some of the earlier pictures as well, both with my wife as well as with my children at different times. So there was not a lot of culture shock, but just being in the hospital day to day and seeing some of the things, I mean, that was very interesting. Certainly a very different approach to healthcare than a lot of what we do, but also remarkable because over the course of my career, I had been able to see the tremendous progress that they had made in going from really a very backwards medical system, very, very, very limited resources, to being able to do a lot of modern techniques, beginning to apply some molecular methods, and having very capable and increasingly specialized people in their practice. So that was a great experience. But the other side of that was, how did I stay up to date, if you will, about a lot of the things that were going on, because I was doing other things besides medical there. And so there were certain things that came into play during that period of time that I missed some of the developments on and had to catch up on when I came back into practice. And so we monitored my diagnostic abilities when I came back into practice to make sure that I wasn't too out of touch. But having been in the hospital system and having seen things, I didn't lose my discriminant abilities or my visual abilities or my memory of what things look like and what they could be.
That's very interesting. I don't think we've heard, I guess, many physicians being able to do something like that. But like you said, I think it goes to show the flexibility academia lends itself.
Yeah.
Another question we had was to do with one of the last cases you presented on, where you mentioned there's certain borderline tumors where if you're seeing more micro capillaries, then it might signal that this is a little more malignant than benign. Is that attributed to the fact that tumors promote blood vessels to grow around them, or is there another reason behind why that is?
So ovarian cancer is really quite unique, and particularly these serous tumors, because they're not highly blood vessel dependent, and they don't spread via lymphatics and blood vessels very much. They tend much more likely to spread via the coelomic surfaces or the abdominal surfaces, the peritoneal fluids, and so forth. That seems to be their preferred method of spread. And that says that they don't tend to promote the same level of vascularity. Now, there are many tumors that produce vascular growth factors. Hepatocellular cancer is notable for producing, endothelial growth factors, and many other tumors where that endothelial growth factor is a key component of the ability of the tumor to invade and survive. Much less so with ovarian tumors. And the borderline term, I think it's kind of unfortunate that we've got that category in one sense, because it kind of sends the message like we don't know what this is going to do. But in another sense, it is saying that this is a tumor that bears watching, and that generally is not going to be responsive to some of the highly toxic chemotherapies. It's not a rapidly growing tumor that's going to respond to a indiscriminate cell cycle inhibitor that shuts down the cell from ever dividing. So it's something that has been used in a variety of organs. Most common application is in ovarian tumors, but because they are difficult to predict. And the other thing that I think that goes along with this is that we haven't yet been able to capture all of the data that's there on the slide. So the genetics and so forth, those are all reflected in the morphology and the character of the cells. And even though there are two tumors that may look very similar and have different genetic or molecular makeups, there still may be subtle clues in the way that they're presented on a slide in a digital image or in a morphologic image that may be able to be extracted and provide more details. And this is what investigations using artificial intelligence and image analysis and various other advanced techniques are trying to do, is to see how much more information we can extract out of these tools that we've been using for hundreds of years to better predict and stratify these tumors. If we were to look at certain types of soft tissue tumors, for example, when I was in training, almost all of the malignant soft tissue tumors were termed, malignant fibrous histiocytoma. They were just a big group of tumors. Well, now we've been able to subdivide off different, more specific variants of that based on morphology and based on follow-up behavior, and increasingly some association with what's going on with the molecular genetics, and then see how that corresponds to their morphology or the way they look under the microscope as well. And so there's sort of this dual process that the imaging or the view of what the things look like in various stains and with various immunohistochemistries tells us one thing. The routine things tend to tell us more things. And then sometimes the biological follow-up allows us to further learn about things that are going to be different. There's a large study many years ago called the tumor genome atlas, or the cancer genome atlas, the tumor cancer genome atlas, TCGA, that took a large number of tumors and did the genome sequencing on those tumors. And that data has then begun to help us to further classify and subclassify tumors, to see where some of the morphologies are telling us things about the genes that we didn't know before, and thus being able to then further classify the diseases into what's going to be treated with one way or another, and so forth. And that's particularly valuable in the GYN tract, where there's one particular type of endometrial cancer that has a very high mitotic or high index of mutations. They have a mutation in the DNA polymerase gene that just leads to tons and tons of mutations. But the prognosis on those cases, which can look terrible under the microscope, is actually wonderful. I mean, it's like 95% survival at 10 years. And so these kind of advances go together with us and really helped us to continue to be stimulated and to continue to learn as we develop in our career.
That's great. Well, actually, the last question we wanted to cover was just about that, about where you see pathology headed, the advances in the field. Are there any other things you want to add on to that?
Well, I think I will just mention where AI may fit in this, because that's kind of where everybody's kind of focused on it a lot. And if we were to look at where AI has been very effective in radiology, it is primarily in being an adjunct to the pathologist, to help them to be more efficient, to help them with quality control, to make sure that they haven't missed things or not evaluated certain things, and then in that sort of double check, or then to think about things that they should have thought of, but may not have thought of. And we're seeing the beginnings of that kind of technology applied to pathology, which I think will make pathologists more efficient and make us more reliable, more robust, more reproducible, which is a bit of a problem, and thus serve patients better. What it's not going to do is replace us, because you really do need to have a lot of IQ points on the front end of this process to make sure that you apply the AI correctly, that you're looking at the right algorithms, that you've managed some of the variables that come in advance of the AI evaluation, and so forth. And so in terms of job opportunities, growth opportunities, pathology is a very understaffed area, and not just in the developing world, where I've talked about the enormous need there is there, but also in the developed world. In our own country, we're now looking at a significant shortage of pathologists due to accelerated retirements during COVID, due to sort of a skewed age demographic distribution amongst pathologists. There's way too many that are gray-haired like me, and so we need more that are young and vibrant to come into the field and to keep it going. Because otherwise, when I get old, my diseases come along, I'm going to want a pathologist there to sort of guide the things. But and your parents will as well. So it's a field where I think there's a ton of opportunity, some very exciting opportunities ahead, and there's really a very nice lifestyle associated with pathology as well. It's we don't get woken up in the middle of the night very often. We don't get called away on nights and weekends to do things, because we've managed to manage our workload into a fairly normal manner, so that you really can have a family life and have other aspects of your life that are still meaningful, while still being involved in a very rewarding profession. So have I made the pitch? Raise your hand if you want to sign up. So
I mean, I was going to just say, like you said, we do need some young pathologists, and I think personally, I've been inspired. I definitely will be taking a lot more serious consideration to the specialty going into med school, and hopefully we've had some other students who are just as inspired. The need is there, and hopefully the inspiration is there too. But what a great session this has been. Just a fantastic session. I learned a lot, like I said, even before we got around to questions. And I'm just very thankful that we were able to have you on, Dr. Hassell, to talk about this great specialty.
Well, it's been my pleasure to be invited, Michael, and I certainly wish all of our viewers, listeners, the very best. And if I can be of help, my contact information is there on my YouTube channel or whatever. Feel free to reach out to me in any way, and I'm happy to engage.
Wonderful. I do have the quiz for those listening in the chat. That's a 10-question quiz about today's session with Dr. Hassell. If you have 6 or more correct, you'll pass and you'll receive a certificate. It'll be sent to the email inbox that you list, the address that you list on the quiz. I also have Dr. Hassell's YouTube channel linked in the video description. He shared a little about how there's a playlist, right, that you have with more specialized pathologists. If you're interested in the field, if the inspiration is there, definitely feel free to check it out. I've hyperlinked it, like I said, in the video description below. Also, for our next shadowing session, we'll be joined by Dr. Dorsey. She's an anesthesiologist. We have her session on Thursday, February 15th at 7 p.m. Central, but we will probably be scheduling a few more sessions between then and now. So be on the lookout for our Instagram page. And also, if you want to join our listserv, feel free to email us. Again, our email is in the video description, or just go to our webpage, our virtual shadowing page, or any of the pages at the very bottom. You'll find a subscription form to join the listserv. But that's all for my reminders. Thank you again so much, Dr. Hassell, for joining us. And if anyone is inspired, like I said, feel free to check out his page. Other than that, I hope everyone has a great rest of your Thursday night, a great weekend, and we'll see you next time.